The redesign of the RN role in primary care. Why did we need this global change? Most of the locations had RN care managers, but it was identified that many of these nurses were not doing the work of a care manager. We knew that we needed to define the roles of the primary care nurses at Virginia Mason Medical Center. We knew that we had to come up with a way to separate the work. We also identified that nurses were not doing the work of RNs only. At least 40% of their time was doing the work of MAs, CSRs, and pharmacists, such as scheduling appointments, calling patients with abnormal lab results, prescription refill requests, giving injections that are within the MA scope of practice. There was no clear direction for nurses. They wore many hats, including but not limited to the on-site role, indirect care, nurse assist, and care management, which made it difficult to prioritize their work. There were no measurements of productivity except for being able to bill for non-face-to-face care management phone calls, but this varied widely across the organization. Their work was pretty invisible. RN staffing levels were not well defined. There was no reliable way to determine how many nurses were needed or which role they would play at each location. Competitive marketplace, recruitment was challenging. Our vacancy rate could be higher at some locations. The very start of this work came from when one location identified that they did not need to replace an RN care manager position, but instead to repurpose that position to an ambulatory nurse role, managing triage and more acute nurse work. The task then began to take a deep dive into the data collection. The data we collected included the processing time of a message sent to the RN to call the patient to the time that the RN opens the message and completes the request. The longest processing times of a message from entering the box to RN triage and documentation was 16 hours and 35 minutes. At any moment in time, there were 112 messages waiting to be triaged across 8 locations. Post-hospital discharge messages were usually around 70 per day. We have a different process for patients that are discharged from our own organization. Urgent emergent calls answered by a clinic RN the first time round was 0 out of 9, which is a 100% defect. Nurses are pulled in many directions. The outcome of the events that took place over a few days was that we were able to identify one pool PC central nurse box for the virtual nurse team. We were able to identify a task by operator sorting tool, a clinic message flow standard work, message by operator sorting tool, a message prioritization tool. We PDSA'd these items while we were implementing the work, which is unusual for these kind of events, but the time was of the essence, so that's how we decided to do it. Any feedback was given to the RN manager just in time. We also developed a playbook. Once we had sorted the work, we were able to divide it into 3 groups. But for the purpose of this presentation, we are going to give you a high view on the on-site role and the care manager role, and provide a deeper dive into the virtual nurse role. The green box describes the role of the newly identified virtual nurse. The 2 blue boxes describe the newly divided on-site and care manager roles, which will be described in more detail on the next slides. There have been some minor changes to these roles since the rollout of this redesign work. The on-site nurses role are responsible for RN triage, such as walk-ins, non-Virginia Mason discharge follow-up calls within 48 hours, and as I said before, our internal transition team do the others. They do RN clinic visits for things such as injection medication teaching for vitamin B12 injections or testosterone injections. They do wound care, diabetes education, such as for a new diagnosis or glucometer teaching, or an insulin start, and then follow that patient for the first month of their titration.